Welcome back to all delegates. Hope you have a good lunch break, even though very short. We have two case discussion here. I hope breast and recurrent trainees to take part in the interactive section and take opportunity to answer questions and opinion. A senior consultant also can interrupt if you want to do so. You can raise your hand and then we will invite into the stage. Okay, our first discussion will be presented by Mr. Chia Cindy from JH Penang. Okay, Chia, you can proceed.
Thank you. So I'll start with the case discussion. Case. So we had a 39-year-old lady who came to us in February last year with a complaint of right breast lump and nipple retraction for 5 months. Para two, breastfed both children and no family history of breast or ovarian cancer. Personal history of recurrent right thigh fibrosarcoma. Underwent white localization and radiotherapy 2008 with recurrence 11 years later. So when she presented to us, it was a T2N1 of size 5 times 5 centimeter with a 2 by 2 centimeter ipsilateral axillary lymph nodes. Mammogram was BRAF 5. There was another small nodule about 1 cm adjacent to the tumor at 12 o'clock position. A palpation-guided core needle biopsy was done initially, and it was reported as high-grade DCIS, but may not be representative of the true tumor, which was 5 times 5 centimeter. So at this point, what are our options? For a clinical T2N1 tumor with high-grade DCIS, do we repeat core needle biopsy or do we offer surgery straight? Any comment from the trainees?
Hi, are you there? Probably you can answer the question.
So anyone can answer the question? I think Chia had given you a question. Siapa dalam ni? Si Azia. Would you like to answer Chia's question? Would you like to repeat the core needle biopsy or you're going to offer the surgery straight away? Yeah, you are muted. Are you there? I think untuk trainee, can you just switch on all your videos so at least we can have a look at you all? Boleh tak on your video, switch on your video so we know that you are around so we can ask you questions. Okay, Amin, since you have the first video on, can you answer the question?
Sorry, because initial presentation I can't hear, so I have to log out and log in back.
Oh, okay.
Roughly dia punya
let me summarize. It's a 39 years old lady with a 5 times 5 centimeter lump, clinical T2N1, mammogram BRAF 5, then a palpation guided core needle biopsy reported as high grade DCIS.
Okay. So looking at the imaging on the first the examination, that is suspicious because this is 5 cm tumor, and it's a freehand core needle biopsy, right?
Yeah.
Probably I will repeat a core needle biopsy with the history and the imaging suspicious. So I will repeat the core, probably this time around guided, ultrasound guided core needle biopsy. Miss Adiba, can't hear you. You're mute.
I think look at your poll punya chat window. The rest can tekan the poll to answer the questions. You can choose either two. Am I right, community members? Okay, on the screen you can see the poll. You can always fill up the poll to poll the answer. Okay. Next one, Chia.
Okay, Chia, proceed.
Okay. Wait, the poll is still okay.
Poll is
Okay.
still reading, is it?
Okay.
Yeah.
All right. So for this question, we discussed the option of repeating core needle biopsy and also an upfront surgery rate because of discordant imaging and clinical finding. But however, she defaulted follow-up and subsequently was referred back to us 4 months later during her follow-up with the oncologist for thigh fibrosarcoma. So at that point, 4 months later, the tumor has increased in size about 1 centimeter, axillary lymph node still mobile, 3 by 2 centimeter. There's the ultrasound image of the axillary node. So this time, we took ultrasound guided core needle biopsy of the axillary node and was reported as it's a ERPR negative and HER2 positive tumor. Staging CT scan showed no distant metastasis. So what are our options now? Do we offer a neoadjuvant chemotherapy, upfront surgery, or any other options available for her?
Suriza, are you there? You all gonna switch on the video. I can't see any of your video here except for Amin. Oh, hi. Hi. Nak answer tak hi? Atau you nak bagi yang lain chance? You are muted.
Hi,
Hi.
please answer question. Hi.
Hi, muted.
Sorry, I'm forgot to unmute.
Okay, you would like to answer the question given?
So this is a clinically T2N1 tumor with the ERPR negative, and the biopsy from the axilla came back as HER2 positive breast cancer. So in this patient, there's with the ERPR negative, there's a benefit of giving neoadjuvant to achieve good PCR.
Okay.
So I would give a neoadjuvant chemo for this patient based on the clinical and also the results of the HPE, which is the ERPR negative with the HER2 positive results.
Okay. Right. I think the polls also answered mostly about 90% answered neoadjuvant chemo. Right. Okay, Chia, you can continue. Okay, Chia. Any comment on your colleague's answer?
Chia, we can't see your slide.
And you are muted too. Chia, can you put up your slide again?
Hello, Chia.
Chia,
Can you listen to us?
your voice tak nampak.
We can't
Tak
hear
dengar,
you.
Chia. Okay. Somebody please help.
Probably Chia have to log out dulu kot.
Dia tak dapat
Chia, we can't hear you. Probably you can refresh your screen back.
Okay, Chia, boleh letak your share slide now?
Yeah, loading up.
Chia, can you share your slide?
Hello. What's happening?
We will start our second case because Mr. Chia having problem with his computer. So I invite Ms. Suriza to share her case presentation. Ms. Suriza, can you switch on your mic? We can't hear you, Ms. Suriza. Ms. Suriza, you can switch on your microphone. Suriza ni tak dengar pun. Alright, Chia, you can continue back. Please switch, share your screen presentation. We're going to continue our session with the lecture from Ms. Adiba. She's breast endocrine surgeon from Hospital Umum Sarawak. Her topic is management approach in huge or retrosternal goiter. Ms. Adiba, please.
Okay, hi, Assalamualaikum, and good afternoon, everyone. Today I've been given a task I've given a task to present retrosternal and management approach. Okay. So the table of contents I'm going to present, going to define the retrosternal goiter, classification, our experience in Sarawak General Hospital, how do we evaluate the patients, whether the patients need conservative approach or operative approach. So is the anatomy necessary for each patient? Surgical techniques. So the aim of surgical techniques is to reduce the morbidity by recurrent laryngeal nerve injury, and going to show some slides for our cases discussion. Okay, so definition, it was first described by Heller in 1749, where it's constitute about 1 to 15% of thyroid surgery. So we often hear, besides retrosternal goiter, there are other terms used like substernal, intrathoracic, mediastinal, plung goiter. So there are few definitions defined of retrosternal goiter. Is either thyroid gland that extend to fourth thoracic vertebra on chest X-ray, thyroid that extend down to aortic arch, was 1950s. Every thyroid that extend below manubrium in 2002, and goiter which more than 50% of it below suprasternal notch. So I think most of the terms and definition that we are using is this, which is more than 50% below thoracic inlet. So a new classification system for retrosternal goiter based on systemic review was published. And then from here, you can have a look that a lot of articles define retrosternal goiter as more than 50% below thoracic inlet. This is the majority, which about 23 papers that have used this term. So classification, mainly there are two. One is primary, which is isolated from ectopic tissue, which this type of gland, they got the blood supply from the mediastinal vessels. And second one is secondary. It's embryological descent from thyroid tissue. Usually they will get the blood supply from the inferior thyroid vessels. So there are other classifications that have been used. One is Higgins classification, Shahian classification, Cohen and Co, Randolph classification. I think most of us are using classification made by Dato' DG, our Dato' Hisham. Okay, so just to highlight the difference between this classification, if Higgins classification, they use percentage of neck. For example, if it is more than 50% the neck, they call it substernal. But if it's more than 80% in the chest, it is used as completely intrathoracic. It's about the same as Cohen-Melchior, but it's using percentage of retrosternal goiter in mediastinal. So for Shahyan classification and Randolph, they are almost similar to our Dato' Hisham's classification. This is mainly based on the anatomical location, whether it is anterior and posterior. So why are we using this classification? Basically, we want to predict the operative approach of this retrosternal goiter. For example, if we look details on Dato' Hisham's classification, we can divide into anterior and posterior. If it's anterior, usually it is classified as an A classification. If A1, it will be isolated. For posterior, it will be at the back. If it is posterior crossover, then you might need to have different approach. Okay, this is our Sarawak General Hospital experience. Okay, this is picture taken before the COVID. That's why we are sitting quite close. Okay, so for Sarawak General Hospital, we are not doing surgery only in Sarawak Hospital. We travel to perform of the thyroid surgeries. So, for example, we went to CCH Bawah PGS Serian Semujan. So, total in 2020, we have done 157 thyroid surgeries. Okay, so retrosternal goiter, in our experience, in 2019, we have done about 9 cases. In 2020, about 11 cases. So, as you can see, it's almost similar to the reported cases before, where we have done about 6 to 7%. So which is reported about 1 to 15%. So around that, 6 to 7% of our cases are retrosternal. So of all the cases in 2019, we have done 1 sternotomy. I think that one can be avoidable because the tumor is hard and fixed and a bit vascular. So we have performed sternotomy. But in 2020, all the 11 cases we have performed can be gone through from transcervical approach. So evaluate. So a lot of question and ask, what are we going to do if we have referral for retrosternal goiter? So there are 2 groups which actually decided to approach for retrosternal. One is conservative and one's intervention. So when I was practiced in UK for previously, most of retrosternal goiter referred actually treated conservatively. It's not as aggressive as what we have in Malaysia, which we have most intervene our thyroid retrosternal goiter. Okay, so for conservative, why this group of conservative group favor conservative? Because was reported that mostly are asymptomatic. So it's about only 1.3 to 3.7 new cases reported. And then they have reported that the greater risk of damage to parathyroid, recurrent laryngeal nerve, and major bleeding. So as you can see the percentage, this is comparison between the normal thyroid and retrosternal, and it will be higher in those who have retrosternal goiter. So of course, there's increased mortality and morbidity. So it was proven in this paper, it was reported that with substernal thyroidectomy, they can have experienced recurrent laryngeal nerve injury with post-operative bleeding and deep venous thrombosis. So they have decided that they only perform the retrosternal goiter surgery for those who have risk of malignancy, those who have symptomatic, like having obstructive symptoms, SBC syndrome, and radiology compression. And the last one is when they're having toxic and on medication. So what about those group which is favor intervention? Okay, so the justification that why we need to do intervention is because those retrosternal goiter, it's very difficult to diagnose. We cannot differentiate between this is benign or malignancy. So because of needle biopsy of the retrosternal goiter is almost impossible. And then 5 to 11 of retrosternal goiter will present at some time with acute airway obstruction. The next one, sudden enlargement due to hemorrhage or malignant change may be life-threatening. So advancing age is also associated with an increased comorbidity. So we don't wait for them to get old. So if they come to us in early age, so it's actually a quite nice time for us to intervene. And then if we perform the early surgery, it's associated with reduced risk of complication. And we can always take some precautions, for example, nerve monitoring to protect, to avoid nerve injury. And then the other thing is a non-surgical treatment with radioiodine is very successful in retrosternal goiter. So next evaluation, whether do we need to perform sternotomy in this patient or not, or can we just approach transcervically? So there are certain, a lot of studies have reported, evaluate, and they have come up predictive value whether these patients need sternotomy or not. So they come up with few predictive factors. For example, if the harder thyroid tissue density, if there is subcarinal extension, if it is located posteriorly, harder thyroid tissue density, and okay, so I think this is about the same. Okay. There's also another study, it's with the title of "Is it possible to predict the need for sternotomy in patients undergoing thyroidectomy with retrosternal extension?" So they have studied about 102 patients. So it was reported that retrosternal extension to aortic root is significantly associated with need for a minimal upper sternotomy. Okay. So extension below the carina, posterior mediastinal extension, presence of an ectopic nodule. So if you can see and compare with classification made by Dr. Isham, it was written that all these isolated and those type B, usually they have higher chance of sternotomy. Conical shape or dumbbell, where the inlet is small and the large component of intrathoracic goiter is big in the thorax. So it's difficult to deliver the thyroid out. So there will be another factor of high risk of proceed with sternotomy. And presence of extension of goiter below the aortic arch. Okay. So what about the surgical technique recommended for this patient? Okay, so the first one is right. So there are important steps to reduce recurrent laryngeal nerve injury. Of course, with ideally is with nerve monitoring. First, we have to strap the muscles to enhance the exposure of the thyroid. And we start with mobilizing the smaller substernal lobe to provide more space in the neck, and division of middle thyroid vein that expose the lateral and posterior parietal space. Then we need to identify the recurrent laryngeal nerve. Sometimes we may encounter difficulty in identification of recurrent laryngeal nerve. Recurrent laryngeal nerve, because with the medial rotation of the thyroid, we can have increase of nerve injury. So we sometimes may need to have a second approach where we cut the isthmus and then we identify the nerve from the incision and then from top to downward, and this is called as toboggan technique. And other techniques can help to safely avoid recurrent laryngeal nerve subscapular dissection or Leahy's modulation technique. But these two techniques, it can cause torrential bleed, and then if it is proven cancer, you may leave the capsule behind. So the best one, if we can take out the whole capsule with the thyroid itself. So basically, that is actually about the approach of the management. Just to summarize, if let's say there's a patient came with retrosternal goiter, so we can predict the surgical approach by first we take the clinical history, whether the patient had history of obstructive symptoms, malignancy, because you can foresee that if it is hard in nature, it is more difficult to deliver it out, like the patient that we had to end up with sternotomy. Okay, and the second one, duration of the duration of the goiter, whether it's a prolonged history, because you can anticipate some problems. And examination is very important. We need to assess whether the thyroid itself is firm, soft, and hard. And then the last one, the most important thing is the CT assessment. Okay, the density of the thyroid tissue, the location, whether it is located posteriorly or it crosses the midline. Extension, whether it is below aortic arch, subcarina, or any addition, any adherence to surrounding tissue. Whether it is isolated primary intrathoracic, whether it's the shape, how's the shape like, related to the thoracic inlet. Let's say the thoracic inlet is quite small and the shape of the tumor, the thyroid is quite large. So you may have difficulty in delivering out. Okay, and recurrent goiter, with recurrent goiter, certain patients may have recurrent and post additions. So this will may anticipate more problem. Okay, for example, this this CT scan. Actually, I wanted to put up the video, but this do not allow me to put up the video. Okay. First of all, okay, when you look at this CT scan, I usually look at the relation of this thyroid with the trachea, okay, and you can see that this is elongated and only one side, okay, so it is mainly anterior, it does not cross to the other side, just a slightly tracheal stenosis is there, okay. So we have managed to remove it out. Okay, this is an example of our retrosternal goiter. So the next slide, okay, if you can see, this is slightly tough for us, where you can see the thyroid gland, it crosses midline, okay, it causes stenosis, and you can see the diameter at the lower part is actually bigger than the smaller part comparatively to the thoracic inlet. So luckily, if the thyroid is quite soft, we can actually deliver it out. Okay, just for a short presentation, I would like to ask, okay, right, I would like to ask some of the trainees to describe some CT, and then you may answer whether can we perform this transcervically or by sternotomy. Okay, so the first case, 65 years old male presented with acute airway obstruction, had history of anterior neck swelling for more than 20 years. So clinically it is firm. Patient was intubated in district hospital and referred to us. So sometimes when patients are from Miri and Cebu, when they're referred to us, so we have to balance whether do we need to bring them over or we have to go there. So certain cases, if we know that anticipating sternal split, then we may need to have the cardiothoracic standby. So that's why it is very important for us to understand to understand evaluation of the retrosternal goiter. Okay. So anyone like I do not want to waste so much time. Okay, so just can somebody just volunteer yourself and describe this scan to me, to every one of us. Can they answer, right? Can I? Okay. Junaidi, you pilih lah. Siapa-siapa? Chia, are you there?
Trainees can raise hand and then raise hand session and then answer the question. Hi, are you there? Please raise hand and then answer question.
Hi.
Yeah, Chia.
Okay. Let me try to describe this CT scan.
Yeah.
It's heterogeneous thyroid lesion involving both the lobes, larger on the right side. I can't really see the inferior extent of this mass.
Okay, I will go to the other slide. This is the inferior extent.
Okay. The problem is this mass right lobe is that it goes retrotracheally and also pushing the esophagus. You can see the rise tube on the left side. So I think this is still above the aortic arch, I think. It goes
It's
behind
below
the...
the aortic arch.
Sorry?
It's below the aortic arch.
Yeah,
That's
below
why if video it will be nicer.
Okay.
Yeah.
Okay, so in this case, I think it is probably difficult to approach this transcervically. We might need a stenotomy.
Okay, all right. So as you can see from the CT scan, it is quite a large tumor, and then after that, when it crosses the midline posteriorly to the trachea, if patient is intubated, if you can see the tube is intubated, so this it crosses the midline. Luckily, we managed to take it out because it is quite a soft tumor. And then I think we did a subclavicular dissection for this patient because patient is intubated. We want to avoid further morbidity. We want to shorten the time of surgery as well. But however, we have decided, I think, tracheostomy, if I'm not mistaken, because patient may need anticipate secretion, prolonged excessive secretion. Okay, the next one, the last one, so this is the one that thyroid that we have removed. Okay, so second case, 55 years old male, referred for anterior nephritic swelling from private hospital in Miri. No history of obstructive symptoms. Okay, next one, siapa? Suriza nak try? Aziah ke? Adi ke? Adi, come. You dari Sibu. Ramai refer this kind of cases. You were in Sibu before. Is Adi around? They need to be in the backstage, is it? Okay, Adi. Yeah. Would you like to describe?
Okay, sorry. My video cannot be turned on for some reason. So this CT scan, you can see there's a on the top. Right-sided goiter pushing the trachea to the left, goes beyond the sternum down until below the arch of aorta. The lower pearl of the lobe is, I think, goes beyond the bifurcation of the trachea as well.
Yeah.
So it's a retrosternal posterior goiter. So I think it's quite challenging if trying to do without a sternotomy.
Okay, so you can see this one is up to the bifurcation of trachea. So to answer whether we can pull up from sternotomy, from transcervical, just wish us good luck because this will be our next case next week. Thank you so much. Thanks. Credits to Prof. Haiza and Mr. Hussein because some slide I might be taking from your side.
Miss Arifah?
Ya. Siapa tanya soalan? Ada? Chat. Q&A, let me see. Tak ada question? Okay. Thank you so much.
Thank you, Ms. Adiba, for interesting talk. Now we move on to our last lecture today. We go to backstage for a while.